Hello, my name's Ian McCall and this is a short talk on androgenetic alopecia in women. Hair loss in women due to androgen hypersensitivity mainly occurs in the central scalp here. They usually maintain their frontal hairline, but they get thinning of the hair behind here. Now what happens over time is that the hair doesn't grow for as long as it should. Instead of growing for 3 years, it only may grow for 18 months and gradually for shorter and shorter periods of time. And the diameter of the hair changes as well. And instead of being a thick terminal hair, it gradually changes into a fine, lighter colored vellus hair. Women usually maintain their frontal hairline, although some women can get the same type of hair loss as male pattern alopecia, where they get loss over the occipital scalp and they get frontal resection here as well, bitemporal resection of the hairline, which is more typically seen in males. If a woman has this pattern of hair loss and also has other signs of androgenization, such as irregular periods or acne or hirsutism, excess hair in other parts of the body, then they should be examined for an androgen secreting tumor. And the area that should be particularly checked is the adrenal glands. And an easy way of doing that is to measure the DHEAS, dihydroepiandrosterone sulfate level, DHEAS level, and see if that's raised. Assuming that there's no underlying direct hormonal producing tumor, and that this is a genetic problem with the conversion of circulating testosterone or progesterone into high intracellular levels of testosterone through the 5-alpha reductase enzyme system, then these patients should be managed in the following ways. First of all, you can use a drug called Minoxidil. Minoxidil doesn't have any effect on the hormone levels in the follicle and the scalp, but it does stimulate hair growth, but only perhaps in about 10% of patients. It will slow down the rate of hair loss in virtually everyone, but you need the 5% minoxidil for it to be effective. 2% is minimally effective, as probably much the same as placebo at about 48 weeks. The 5% minoxidil shouldn't give much in the way of side effects. You may get some irritation of the scalp. Minoxidil itself was used initially in treating hypertension, high blood pressure. And what they found was that as well as lowering the blood pressure, it tended to lead to increased hair growth in the body. And so that's why a topical preparation was developed. But usually not enough is going to be absorbed across the scalp to cause any significant reduction in blood pressure, though there may be a local contact irritation reaction in the scalp. The minoxidil comes in the form of a lotion that can be, it's usually 1 ml applied twice daily, or in the form of a foam. There are generic variants of it available nowadays, so the original Rogaine, which was made I think by Roche, you can get a generic variant that's much less expensive and just as effective. The thing about minoxidil is that if you cease using it, if you do get some hair regrowth and you cease using it, then within 3 months all that hair that has regrown will all fall out again. So if it works, you're condemned to using it for the rest of your life. The other preparation that can be used for female pattern alopecia is the other one we mentioned there, oral spironolactone. Spironolactone or aldactone is a diuretic, it's a water tablet, but it has a mild anti-androgen effect. And so it's useful in male pattern alopecia. It's also useful in hirsutism elsewhere, where you get excess hair, and in people with acne. So it's a useful drug, this, usually at 100 to 200 milligrams daily, but it has to be taken for a period of 12 to 18 months to really assess its effectiveness. Again, it will tend to slow down the rate of hair loss, but the question of whether you'll get significant hair regrowth is debatable. It used to be said that you had to check potassium levels every 6 months or so when you were on this drug, but recently I think that's been found to be unnecessary. The risks of hyperkalemia, raised potassium levels, is really quite small, unless someone's addicted to bananas and they're taking 6 bananas a day that might have high potassium in them. The other drug that's mentioned there is finasteride. Now, this is a 5-alpha reductase inhibitor, so it stops that conversion of circulating testosterone into intracellular testosterone. But the drug's only really of value in postmenopausal women, and even then, the studies have shown that, it's probably only marginally effective. It's perhaps more effective for those women who have the true male pattern loss with, resection of the frontal hairline and a more occipital hair loss pattern. It's not quite as effective in this group, even in the postmenopausal group of patients. So the drugs that are available to treat female pattern alopecia are actually limited to really minoxidil and oral spironolactone. It's interesting, the change in the density of hair that you get here. The hairs become smaller, they become lighter colored, they change from terminal hairs into what are called vellus hairs. Vellus hairs are the very fine hairs that you get in babies. But of course, it takes a long, long time for that to occur. And in women early on, the useful way of looking at this is a widening of the part line and a reduced density of hair either side of the part line. This is more prominent after the hair is shampooed or wet, but this is the easiest way to assess this type of hair loss early on. It can occur in the early 20s, but it's perhaps more common just prior and after the menopause in women. So this is female pattern alopecia. The other time when this may become a little bit more prominent is if someone has associated telogen effluvium. Now that's where, say, you've got a crash diet, or you've had a general anesthetic, or some other insult like this, and a lot of and hairs, instead of growing their normal 3 years, just all may suddenly stop growing at once and fall out, and then suddenly you expose this sort of pattern alopecia here. With telogen effluvium, you get loss of hair all over the scalp, but if you've got a tendency to this, it may suddenly become more prominent when you've had an associated bout of telogen effluvium. So that's the other time that this may be noted for the first time. So, female pattern androgenetic alopecia is not an uncommon problem. You need to lose a fair bit of hair before it becomes obvious, but we're seeing quite a bit of it in clinical practice. So I hope that's given you a better understanding of this condition. Thank you very much.